1, 2,
And maybe 70-year-old female
Oh shit, almost got some blood going. Oh, he's wearing it too.
You're in the bay. Once you get over to the bed, we'll give you the story. Everything's going to happen super fast. Welcome to the emergency room.
I lost the pulse.
It's charter book.
300 please.
I'll keep you on again.
Pulse check. No pulse.
No more pulse.
Yeah. Here, what do the ECMO people say? And her blood pressure is off the dropping.
45 minutes of CPR and no return of circulation. Okay.
So, you walk into the ICU. Bed 4's monitor is alarming.
Oh, always a great start to this shift.
Right. The heart rate is like 135. Blood pressure is drifting down. The MAP is barely hanging on to 60. And your patient is looking increasingly somnolent.
Yeah, they're fading fast.
Exactly. And your immediate instinct, I mean, the instinct of pretty much most clinicians is to look for those obvious catastrophic events.
You want the quick answer?
Yeah. Are they septic? Did they throw a pulmonary embolism? Is there a tension pneumothorax? We all want a clean binary diagnosis.
But critical care is rarely that clean.
It really isn't. So today, in this deep dive, we are stepping into a diagnostic landscape that is incredibly murky. It's deceptive. We're looking at the ultimate physiological masquerader, which is anemia.
It truly is the great imitator in critical care.
It really is.
And for you listening, whether you're an ICU nurse, a resident, or just someone trying to master critical care thinking this is going to be an intense masterclass in how human systems fail.
Yeah, we're not holding back today.
Because when we talk about hematologic problems, we aren't just talking about a low number on a lab printout. We are talking about the fundamental disruption of cellular life.
Right. And our mission today is to totally tear down the superficial understanding of this condition. We are adopting a strict intensivist mindset here.
Which means we need to understand the failing physiology.
Exactly. How does the body compensate when the oxygen delivery system breaks? When does that compensation tip over into total, irreversible decompensation?
And most importantly, how do you recognize those clinical red flags before your patient goes into cardiac arrest?
Because that's the ultimate goal, right? Saving the patient. So to really grasp that failing physiology, you have to look at what blood is actually doing second by second.
It is the body's ultimate multitasker. I mean, it maintains homeostasis, fluid volume, perfusion. When hematologic systems fail, the fallout is systemic.
It's everywhere.
Yeah. If immunity is compromised, say, in hematologic cancers or from the therapies used to treat them, the patient is at immediate severe risk for opportunistic infections.
And then there's the pain aspect.
Oh, absolutely.
Which is profound in conditions like sickle cell disease, right?
Yeah.
Where the blood itself becomes like a physical weapon against the tissues.
It's excruciating. And we also cannot ignore the clotting cascade.
Right, because clotting is supposed to be this vital protective mechanism.
But it requires a really delicate equilibrium. If that system misfires and hypercoagulates, it impairs perfusion. Tissues literally infarct and die from a lack of blood flow.
Just total starvation of the tissue.
Exactly. And on the flip side, inadequate clotting leads to severe hemorrhage and catastrophic fluid volume deficit. But all of this circles back to the core issue we are focusing on today.
Yeah, and here's where I really want to challenge a major misconception that I think a lot of us have. We document anemia in patient charts constantly.
Every single day.
We code it for billing. We treat it like it's a standalone disease. But physiologically, that's completely inaccurate, isn't it?
It is entirely inaccurate. And this is the crucial paradigm shift you must make if you want to think like an intensivist.
Okay, lay it on us.
Anemia is never the primary disease. It is purely a manifestation of an underlying pathologic process.
So it's the smoke, not the fire.
Precisely. It is an alarm bell ringing in the system.
Yeah.
The clinical mission, your job at the bedside, is to find out what is actually on fire.
Because if you just transfuse packed red blood cells to treat the low hemoglobin, you're just fanning away the smoke.
Right. If you don't find the bleeding ulcer or the bone marrow failure or the hemolytic trigger, the house is still going to burn down.
Wow. Okay, so let's get into the detective work. We know it's a symptom, but how do we define and track it on a cellular level?
Well, the strict triad definition is a deficiency in the number of erythrocytes, a deficiency in the quantity or quality of hemoglobin, and or a deficiency in the volume of packed red blood cells, which is the hematocrit.
Okay, so to catch this, we rely on 3 initial diagnostic tools, right? The complete blood count, or CBC, the reticulocyte count, and the peripheral blood smear.
Yeah, and out of those three, I really want to emphasize the reticulocyte count.
Why that one specifically?
Because that is your first major branch point in clinical reasoning. Reticulocytes are immature red blood cells.
Okay.
When you see a patient with severe anemia, you have to look at that retic count to understand what the bone marrow of the factory is doing.
Let me make sure I'm conceptualizing this correctly. Diagnosing this kind of feels like realizing a massive delivery company is failing.
I like that analogy.
Yeah, so you're the customer, and the packages, which in this case are molecules of oxygen, simply aren't arriving at the tissues.
Right.
So to fix the company, you have to find the exact point of failure. Are the delivery trucks themselves built incorrectly? Are there simply not enough drivers showing up to work? Or is the cargo being hijacked out on the highway?
That analogy maps perfectly to the hemodynamics. I mean, if your oxygen delivery, your DO2 is failing, you have to know why. And that reticulocyte count tells you if the factory knows there's a problem.
So, if the patient is highly anemic, but their retic count is elevated, what does that mean?
It means the bone marrow is healthy. It's frantically pumping out new, immature cells to replace the ones being lost or destroyed on the highway.
The factory is working overtime.
Exactly. But if the patient is anemic and the retic count is low, your factory's broken. It's either out of raw materials or the machinery itself has just shut down.
Which leads us directly into how we classify this failure. We have two distinct systems, right? Morphologic and etiologic.
Yeah, let's start with morphology.
That's the what does it look like approach under the microscope. And it's based on mean corpuscular volume, the MCV, and mean corpuscular hemoglobin, the MCH. Basically size and color.
Right. Morphology is incredibly accurate scientifically. We divide it into three buckets. First, you have normocytic, normochromic.
Meaning normal size, normal color.
Exactly. The cells are the right size and the right color, meaning your MCV and MCH are perfectly normal. There just aren't enough of them.
Going back to the delivery analogy, the trucks look fine, there's just a massive shortage of them. But the etiologies here are wildly diverse. We're talking acute blood loss, hemolysis, chronic kidney disease, endocrine problems, starvation, aplastic anemia.
It's a wide net.
It is. I mean, it seems counterintuitive to group acute traumatic hemorrhage in the exact same cellular category as chronic starvation.
It does seem strange until you look at the pathophysiology of the cell itself.
Yeah.
In both acute hemorrhage and starvation, the body hasn't lost the blueprint for how to make a red blood cell.
Oh, I see.
In hemorrhage, it's just losing them faster than it can make them. In chronic kidney disease, the kidneys stop producing erythropoietin.
And erythropoietin is the hormone that tells the marrow to work, right?
Exactly, the EPO.
Yeah.
The factory is simply told to slow down, but the few cells it does produce are structurally sound.
Okay, that makes sense. So moving to the second morphologic bucket, microcytic, hypochromic, small size, pale color. Both MTV and MCH are low.
Yes?
We see this in iron deficiency, vitamin B6 deficiency, copper deficiency, thalassemia, and lead poisoning. Explain the mechanism here. Why do they shrink and lose their color?
It all comes down to hemoglobin synthesis. Hemoglobin is a massive, complex protein structure built around iron.
Right, iron is the core.
It's what gives the cell its rich color and plumps up its volume. If you lack iron, or if you have a genetic defect like thalassemia that prevents you from building the globin chains, you literally lack the physical mass to fill out the cell.
So the bone marrow pushes out these defective, tiny, pale cells. You don't have the steel to build a proper delivery truck, so you build a fleet of, like, pale little golf carts that can barely carry any oxygen.
That is exactly what happens. And lead poisoning is a really fascinating inclusion here.
Yeah, I was wondering about that. Why lead?
Because lead physically blocks the enzymatic pathways the body uses to incorporate iron into the hemoglobin molecule. You might have plenty of iron in the body, but the lead acts as a saboteur on the assembly line.
Wow, so the iron is there, but the factory workers can't use it.
Precisely.
Okay, then we have the third bucket, macrocytic or megaloblastic, normochromic. The cells have a normal color, but a massive size. The ACV is elevated.
Yes, the giant cells.
We associate this with defective DNA synthesis, driven by cobalamin or folate deficiency, as well as severe liver disease. But I have to push back here. Why would defective DNA make a cell bigger? You'd think a defective cell would be stunted or shriveled.
It's a great question, and it's all about asynchronous maturation.
Asynchronous maturation. Break that down for us.
So, when red blood cells develop in the bone marrow, they start out as massive precursor cells. As they mature, they're supposed to divide, condense their nucleus, and shrink down into that tight, efficient biconcave disc we are familiar with.
The classic donut shape.
Right, but that division process requires rapid DNA replication.
And B12 and folate are required for that DNA synthesis.
Yes, so without them, the cytoplasm of the cell keeps growing, RNA synthesis continues, but the DNA cannot replicate to allow the cell to divide.
Oh, so it just swells up.
You end up with this giant, clumsy, oversized cell. And because its structure is so abnormal, the cell membrane is incredibly fragile.
So it breaks easily.
Exactly. These megaloblastic cells often undergo apoptosis-programmed cell death right there in the bone marrow. Or, if they do make it out, they get easily destroyed once they hit the turbulent circulation.
Okay, now, morphology is great for the lab, but in the ICU, we lean heavily on the etiologic classification, the why is it happening approach.
Because it dictates treatment.
Right, because if my patient is actively crashing, knowing their cells are microcytic doesn't tell me how to save their life in the next 5 minutes. I need the etiology to establish my priority nursing actions.
And etiologically, there are only 3 ways this system fails. Number 1, decreased red blood cell production. Number 2, blood loss. And number 3, increased RBC destruction or hemolysis.
Let's view this through an intensivist lens. Starting with decreased production, so the factory is broken. This could be lack of nutrients, bone marrow suppression from chemotherapy, or decreased erythropoietin from renal failure.
Right.
From an ADPIE perspective, assessment, diagnosis, planning, implementation, evaluation, what is the immediate threat here, and what is our action?
The insidious thing about decreased production is that it is usually chronic. The body has time to compensate.
So they might look okay first.
Yes, their baseline is adjusted. Your immediate threat is usually sudden, excessive exertion, or a superimposed infection that pushes their baseline oxygen demand beyond what their limited supply can handle.
So what's the nursing priority?
Your independent nursing actions involve massive energy conservation. Cluster your care. Do not force this patient to expend oxygen they don't have.
So no unnecessary trips to the chair, keep the room calm.
Exactly. And your collaborative implementations involve replacing the missing elements. You might be administering synthetic erythropoietin, IV iron, or ultimately a packed red blood cell transfusion if they become hemodynamically unstable.
And how do we evaluate if that worked? How do we know the factory is back online?
You watch that reticulocyte count. If you give IV iron or erythropoietin, you should see the red count spike in a few days.
Because the new cells are hitting the bloodstream.
Right. That tells you the bone marrow has received the supplies and turned the assembly line back on.
Okay, let's pivot to the second etiology, blood loss. The bucket has a hole. This is where critical care gets incredibly intense.
It gets very fast-paced.
Yeah. We divide this into acute and chronic. Chronic is your bleeding duodenal ulcer or colorectal cancer, a slow leak that masks itself through compensation. But acute blood loss trauma, ruptured aortic aneurysm, a massive GI bleed, this is a hemodynamically violent event.
This is hemorrhagic shock. The problem here isn't just that you are losing oxygen carrying capacity, you are losing massive intravascular volume.
Walk me through the failing physiology here. What is happening minute by minute?
Let's look at the hemodynamics. Cardiac output equals heart rate times stroke volume.
Right, HR times SV.
Stroke volume is heavily dependent on preload, the amount of blood returning to the right side of the heart. When a patient abruptly loses 20 or 30% of their blood volume, preload plummets.
So the tank is empty.
The heart suddenly has nothing to pump. Stroke volume crashes. To maintain cardiac output, the sympathetic nervous system kicks in and fires the heart rate into the 130s or 140s.
So you get that massive tachycardia. At the same time, they are trying to protect the mean arterial pressure, the MAP, and MAP is cardiac output times systemic vascular resistance, the SVR.
Exactly. Because cardiac output is dropping despite the tachycardia, the body slams the peripheral blood vessels shut to increase SVR.
So they clamp down.
That's why your bleeding patient is pale, cold, and clammy. The body is sacrificing the skin, the gut, and the kidneys to keep blood flowing to the brain and the heart.
Wow. The patient is getting worse if their MAP drops below 65, their urine output drops below 30 millimolars an hour, indicating acute kidney injury from lack of perfusion, and their mentation changes.
Yes, the brain is starving.
If they become confused or lethargic, you are losing brain perfusion. This is a rapid response, immediate escalation scenario.
And your priority nursing action here is not just giving oxygen. Oxygen doesn't help if there's no fluid to carry it.
Right, you need the trucks.
Your first action is establishing large bore IV access, 18 gauge or larger. Then you aggressively resuscitate with isotonic crystalloids. Or, ideally, initiate the massive transfusion protocol, the MTP.
And what's the ratio for MTP?
You need to replace volume and oxygen carrying capacity simultaneously, usually in a 1:1 ratio of packed cells, fresh frozen plasma, and platelets.
Why all three? Why not just packed cells?
To prevent dilutional coagulopathy, if you just give red cells, they won't be able to clot and they'll just keep bleeding out of their wounds or their GI tract.
It's a literal race against time. Which brings us to the third and final etiologic category, and arguably the most complex. Increased RBC destruction. Hemolysis. The cells are being actively destroyed faster than they can be made.
This is a highly volatile state. The threat here isn't just hypoxia, it's the toxic debris left behind by exploding red blood cells.
We split this into intrinsic and extrinsic destruction. Intrinsic means the cells have a hereditary defect, they are built wrong. Sickle cell disease is the classic example here. The hemoglobin is abnormal, and under stress it polymerizes, causing the cell to warp into a rigid sickle shape.
And from an ICU perspective, a sickle cell crisis is a microvascular catastrophe. Those rigid cells get physically wedged in the capillaries. We create a logjam.
And nothing can get past it?
Right. This causes downstream tissue ischemia and infarction, which is agonizingly painful.
So if you see a sickle cell patient in severe pain with dropping oxygen saturations, what are your priority actions?
Think atropine. Hydration, oxygenation, and pain relief. You aggressively hydrate them with IV fluids to decrease blood viscosity and try to physically flush out those microvascular jams.
You're trying to thin out the sludge.
Exactly. You provide supplemental oxygen to reverse the sickling trigger, and you implement high-dose 5E narcotics for the pain.
Because the sheer stress of the pain will increase their metabolic oxygen demand and make the crisis even worse.
Yes, pain control is an oxygenation intervention in this case.
Okay, what about extrinsic destruction? The cells are perfectly normal, but outside forces are hunting them down.
These are acquired conditions, and they are terrifying. It could be an autoimmune response where antibodies attack the RBCs. It could be infectious agents like malaria where the parasite physically bursts out of the cell. Or it can be mechanical destruction.
Mechanical destruction is fascinating to me. You can literally smash your blood cells to pieces.
You really can. Extracorporeal circulation, like a cardiopulmonary bypass machine or ECMO, has rollers and pumps that physically shear the red blood cells as they pass through.
Just grinding them up.
Yeah. Even a mechanical prosthetic heart valve can chew up blood cells as it snaps shut 100,000 times a day. And then there are microangiopathic hemolytic anemias, like DIC or TTP, where microscopic fibrin strands form a web inside the blood vessels.
Like a cheese grater in the veins.
Exactly, and the red blood cells get sliced in half as they try to push through.
And what's the major complication we need to watch for in all these hemolytic states?
Acute tubular necrosis, or ATN.
In the kidneys.
Yes. When red blood cells explode in the bloodstream, they release free hemoglobin. Free hemoglobin is highly toxic to the microscopic tubules of the kidneys.
So how do we assess for that?
If you see a patient with suspected hemolysis and their urine suddenly turns dark, tea-colored, or even black, that is hemoglobinuria, the kidneys are literally choking on the cellular debris.
That's a terrifying visual.
It is. Your priority action is aggressive IV hydration to literally flush the kidneys and maintain a high urine output to prevent permanent renal failure.
Okay, so let's transition from the specific causes to the universal pathophysiology. We know what causes anemia, but how does it systematically dismantle a patient?
We have to follow the hypoxia cascade. The primary trigger for everything we're about to discuss is tissue hypoxia. The cells of the body are suffocating.
Okay.
And without oxygen, they cannot utilize aerobic metabolism to create ATP.
So they shift to anaerobic metabolism.
Exactly. And the byproduct of anaerobic metabolism is lactic acid. As lactic acid builds up, the blood pH drops, causing metabolic acidosis.
And acidosis is terrible for the body.
It impairs enzyme function, decreases myocardial contractility, and sets the stage for multi-organ failure. Every clinical manifestation of anemia, every symptom, is the body's desperate, escalating, and ultimately failing compensatory response to this hypoxia.
Let's track that deterioration using the hemoglobin levels. The first stage is mild anemia, an HGB of 10 to 12 grams per deciliter.
Often completely silent. The patient may not even know they have it unless they engage in heavy exercise.
I want to dig into how the body compensates here because I think it's brilliant. If the hemoglobin is low, how does the body ensure the tissues still get enough oxygen at rest?
It alters the affinity of hemoglobin for oxygen.
How so?
The body increases the production of a molecule called 2-card3-DPG within the red blood cells. 2,2-DPG binds to the hemoglobin and essentially forces it to let go of oxygen more easily.
It makes it less sticky.
Yes, this causes a rightward shift in the oxyhemoglobin dissociation curve. So even though there are fewer delivery trucks, the trucks are programmed to dump their cargo much more readily the second they reach the tissues.
That is incredible. The body just adapts on a molecular level, but that mechanism has a ceiling, right? Once we drop into moderate anemia and HGB between 6 and 10 grams per deciliter, the shift is no longer enough.
Right. The alarm bells are ringing. You start seeing cardiopulmonary symptoms, palpitations, shortness of breath, fatigue happening at rest.
When you see symptoms at rest, what does that tell you as an intensivist?
It tells me their compensatory reserve is gone. The heart and lungs are working overtime just to maintain baseline survival while the patient is lying completely still in bed.
So they have no buffer left.
None. If they get a mild fever or if they have to get up to use the bathroom, that slight increase in oxygen demand could crash their system.
Which brings us to the precipice. Severe anemia, an HGB of less than 6 grams per deciliter. This is systemic decompensation.
This is where we see the physical manifestations of multi-organ starvation. Let's look at the assessment, starting with the integumentary system.
The classic sign is extreme pallor. But this isn't just because the blood is lacking red pigment, right? It's a hemodynamic defense mechanism.
Yes. The body is making a ruthless calculation. The brain and the heart must survive, but the skin is expendable.
So it cuts off the skin.
The sympathetic nervous system releases norepinephrine, which binds to alpha-1 adrenergic receptors in the peripheral blood vessels, causing profound vasoconstriction. The body actively shunts blood away from the surface. The pallor is visual proof of peripheral ischemia.
We also see jaundice and pruritus, the severe itching. As we discussed earlier, this is specific to hemolytic anemia, right?
Yeah.
Massive RBC destruction releases bilirubin. The liver is overwhelmed, so unconjugated bilirubin deposits in the skin and sclera, turning them yellow, and the bile salts deposit in the skin, irritating the nerve endings.
If you see a patient who is severely pale, rapidly becoming jaundiced, and scratch themselves raw, you should immediately suspect the hemolytic crisis and anticipate rapid renal and hepatic decline.
But the most critical section of our assessment is cardiopulmonary failure. This is what ultimately kills the severely anemic patient.
The physiological pivot here is the heart attempting to save the suffocating body through high output compensation.
Let's go back to our formula. Cardiac output equals heart rate times stroke volume. If the body senses tissue hypoxia, it demands more cardiac output to cycle the remaining blood faster.
To achieve that, the heart rate spikes severe tachycardia. But the stroke volume also increases. The heart is beating faster, and it's squeezing harder with every single contraction.
And there's a fascinating physical consequence to having fewer red blood cells. The blood literally becomes thinner. It has low blood viscosity.
It's basic fluid dynamics. Normal blood has a certain thickness, which allows it to flow smoothly in a laminar pattern.
Like honey.
Yeah, kind of. But when you remove a huge portion of the red blood cells, the blood becomes watery.
So you have watery blood, and the heart is violently slamming it into the aorta.
Exactly. This causes the Reynolds number, a physics equation for fluid flow, to skyrocket. The flow changes from smooth and laminar to chaotic and turbulent.
And you can actually hear this, right?
Yes. This turbulence creates physical vibrations. When you put your stethoscope on the patient's chest, you will hear loud systolic murmurs over the heart and bruits over the major arteries like the carotids.
When a nurse hears that rushing murmur in an anemic patient, they aren't just hearing a heart valve issue, they're hearing the physical reality of thin, oxygen-starved blood racing out of control.
But here's the fatal flaw in this entire compensatory mechanism. The heart is a muscle. It is doing an incredible amount of mechanical work to beat 130 times a minute with maximum force.
Which means the myocardial tissue itself has a massive demand for oxygen.
Yes, but what is the only blood available to feed the coronary arteries?
Into the severely anemic, oxygen-depleted blood.
Exactly. It is a vicious, catastrophic cycle. The heart is frantically working itself to death, starving for oxygen to pump blood that doesn't have enough oxygen to sustain the effort.
So the myocardium itself becomes profoundly ischemic.
The patient will develop angina pectoris, severe chest pain. And if this isn't reversed immediately, they will suffer a type 2 myocardial infarction.
A type 2 MI.
A heart attack caused not by a blocked artery, but by a supply and demand mismatch. The heart muscle dies from sheer exertion without fuel.
And once the myocardium infarcts, the pump fails entirely. This is terminal decompensation.
The assessment findings here are grim. Heart failure sets in. The heart dilates, resulting in cardiomegaly. Because the left ventricle can no longer pump against the systemic vascular resistance, fluid backs up into the lungs, causing severe pulmonary edema.
So you'll hear crackles on auscultation, and the patient will be drowning in their own fluid.
Then the right ventricle fails, and fluid backs up into the systemic circulation. You see massive peripheral edema, hepatomegaly, and ascites in the abdomen. The patient is in cardiogenic shock.
And your nursing actions here are highly complex. I mean, you have a patient in heart failure, so your instinct is to give diuretics to clear the fluid, but they are severely anemic, so their oxygen carrying capacity is already critically low.
This is where intensivist thinking is paramount. If you diurese them too aggressively, you drop their preload, their cardiac output crashes entirely, and they die.
But if you give them massive blood transfusions too quickly to fix the anemia,
You overwhelm the already failing heart with volume, worsening the pulmonary edema, and they die.
so what do? How do you treat this?
You have to walk a razor's edge. You administer packed red blood cells incredibly slowly, often 1 unit over 3 to 4 hours, and you frequently administer the 5E furosemide Lasix between units to gently pull off the extra plasma volume while retaining the red blood cells.
So 1 unit of blood, then some Lasix, then wait.
Yes, very delicate titration. You may need to place them on positive pressure ventilation like BiPAP or intubation to force oxygen across the fluid-filled alveoli and decrease the work of breathing.
Because breathing takes energy they don't have.
Exactly. And you support the heart with inotropes like dobutamine to help it squeeze without demanding too much extra oxygen.
It is a profound tightrope walk, and it perfectly highlights why you can never look at a lab value in isolation. A low hemoglobin isn't just a number to correct, it's a structural collapse of the cardiovascular system waiting to happen.
It requires relentless reassessment. You don't just hang the blood and walk away. You are continuously monitoring their respiratory status, their CVP, their urine output, and their mentation.
Well, on that intense clinical note, we have reached the end of our deep dive into the failing physiology of the blood. If you take one thing away from this, it's that anemia demands your critical respect.
Absolutely. To wrap things up, we promised you the elite ICU intensivist summary.
Here it is. If you remember only 5 things from this entire discussion, lock these into your brain. Number 1, core pathophysiology. Anemia is fundamentally driven by tissue hypoxia. Every single symptom, from pallor to tachycardia, is just the body's escalating compensatory response to cellular suffocation.
Number 2, key assessment finding. Symptom severity tracks directly with hemoglobin levels, but the major red flag is symptoms at rest. If a patient is experiencing cardiopulmonary distress while sitting still, their compensatory reserve is totally exhausted, and they are on the verge of decompensation.
Number 3, the most dangerous complication. Unrelieved severe anemia forces the heart to work so relentlessly hard, without sufficient oxygen to feed its own tissues, that it triggers myocardial ischemia, type 2 myocardial infarction, and irreversible high-output heart failure.
Number 4, priority nursing action. Look past the lab value and identify the etiology immediately. Is it a production failure, a hemorrhagic leak, or a hemolytic explosion? Your immediate interventions, whether it's energy conservation, the massive transfusion protocol, or aggressive hydration to protect the kidneys, depend entirely on knowing the source of the fire.
And number 5, the most important treatment. Treat the underlying cause, not just the number. Giving packed red blood cells without stopping the GI bleed or fixing the B12 deficiency is a temporary Band-Aid on a fatal wound.
Here is your one-sentence clinical picture for severe anemia. A tachycardic tachypneic, profoundly pale patient with a bounding pulse and a systolic murmur, whose heart is failing as it desperately attempts to circulate thin, oxygen-depleted blood.
And finally, our intensivist rule of thumb. If you see a rapidly dropping hemoglobin coupled with new onset chest pain, shortness of breath, and a murmur, think impending high-output heart failure and myocardial infarction, and immediately prepare to carefully transfuse packed red blood cells while monitoring closely for volume overload.
A sobering reminder that in the ICU, the compensatory mechanisms designed to keep a patient alive are often the very forces that will destroy them if we don't intervene.
Incredible stuff. Keep thinking critically, keep looking for the fire, and until next time, keep diving deep.